BRAF mutations occur in half of all melanoma patients, and again, they may actually carry prognostic value, but most importantly, I consider them the most predictive test that we have in melanoma because they predict for responses to targeted therapy that with BRAF and MEK inhibition. And so, generally speaking, since we think about them in the setting of when are you going to use that targeted therapy, we started testing in metastatic disease because that's where the combination of dabrafenib and trametinib, vemurafenib, cobimetinib, and now encorafenib and binimetinib have all proven benefit. However, I think the earlier that you can find out, the better off your patient will be because you will always know whether you have that option at your disposal. And this became very true after the adjuvant data from COMBI-AD was published, and now we have an approved adjuvant therapy for that setting. So now stage 3 patients need to be tested. So we generally test all patients that have a positive lymph node. And we're starting to think about whether we should even test earlier stage patients. And there are considerations for trials now for even stage 2 patients. And so I guess my answer to this would be test as early as possible and as soon as possible so that you know where your patient kind of fits in the treatment paradigm. Biomarkers of response in melanoma are not well established. Again, I think the BRAF mutation is probably the best biomarker that we have because it consistently predicts for response to BRAF inhibitors. PD-L1 testing, can kind of help understand the response of a patient, but I don't honestly think that it predicts the response as well as we would like it to, so we don't reflexively test all of our patients for PD-L1. We do test it typically on clinical trials and most of the time actually more retrospectively. So again, in melanoma, PD-L1 is not very useful as a marker of what you should do for your patient. Similarly, TMB has been reported to be associated with response. So the higher TMB, as you would expect, you have a higher mutation burden, you would expect most patients to respond. I'm not sure that it's necessarily an independent predictor, though. Again, you would find some of the TMB high patients will be PD-L1 positive. They also may have a high interferon gamma signature, so all of these subsets end up overlapping. And again, TMB itself is not kind of independently predictive, so we don't use it for clinical management at this point.